Welcome. Thank you for joining Getting Telehealth Policy Right, a national summit. I am Susan Hepworth, Director of Patient and Provider Advocates for Telehealth, which is convening today's summit. Patient and Provider Advocates for Telehealth is a coalition of patient advocacy organizations and medical societies focused on advancing policies that ensure access to telehealth beyond the public health emergency. I'll be joined throughout the day by my colleague Amanda Conshafter from the Alliance for Patient Access, who will help facilitate today's discussions. We want to thank our co-hosts, the Alliance for Patient Access and Institute for Patient Access, as well as the generous sponsors who made today's program possible: Amgen, Horizon, Johnson & Johnson, and Neurocrine Biosciences. On the live stream page you're currently viewing, there are two boxes, one for question and answer and polls, and the other for interacting with fellow attendees. Some of today's summit segments will feature an opportunity for audience question and answer, or we might ask the audience some questions using the polling feature. If we have time for questions during some of our segments, type those into that box, click send, and your question will be added to the queue. We'll let you know at the beginning of each segment if we have allotted time for questions. And please interact with fellow attendees using the chat box on the right side of your screen. We will also put relevant resources and links in the chat box throughout today's discussions. And if you're on social media, we encourage you to use the hashtag TelehealthSummit21 and follow us on Facebook and Twitter. Search Patient and Provider Advocates for Telehealth. We will also post links to our social media in the chat box. As you scroll through the live stream page, you'll find information for all of today's speakers, the agenda, and a variety of resources from the coalition. We encourage you to download and share those resources, and know that you can also find out more information about the coalition at telehealthadvocates.org. Now, it's my pleasure to introduce Dr. David Charles, who will deliver the summit's opening remarks. Dr. Charles is the founder of the Alliance for Patient Access and a practicing neurologist at Vanderbilt University. Dr. Charles, take it away.
Thank you, Susan. Good morning, everyone. I'm David Charles, and I'm pleased to join you this morning from Nashville, Tennessee, to touch on an issue that's near and dear to my heart: telehealth. Today's summit is yet another reminder of telehealth's reach, its popularity, and its value to millions of Americans. And it's continuing to grow. It's also an opportunity to celebrate telehealth as a positive development amid the many challenges that our healthcare system, in fact, our nation, has faced during the COVID pandemic over the last year and a half. For me, this event is rewarding on a very personal level. As Susan mentioned, I'm a practicing neurologist, but I'm also the medical director of telehealth at Vanderbilt University Medical Center. And for some years now, a group of physicians like me have advocated for greater access to telehealth. Remote visits using technology to connect patients and healthcare providers. But a lot of people felt the idea unnecessary, maybe even futuristic or far-fetched. And to insurance companies, it sounded expensive. Health plans refused to cover telehealth because they worried it would be overused. It seemed to me that kind of in their mind, they were just thinking Americans would sit around on their couch all day, doing nothing but one telehealth visit after another from their couch. It took more than my voice or any single voice to change their minds. It took a pandemic. It took a dramatic shift in how people think about life, their health, access to health care. And it really took all of our voices: patients, physicians, caregivers, advocates, policymakers, to bring about the changes that we've seen. Today gives us a chance to hear some of those voices. We'll hear how telemedicine visits eliminate the logistical hassles of going to see the doctor, navigating traffic, parking in a parking deck, waiting in the waiting room. We'll also hear about people who live in rural or underserved areas. In my state, 1 in 4 Tennesseans lives in a health profession shortage area, and they often don't have access to subspecialty care. Telehealth really greatly addresses that. We'll hear how telemedicine benefits healthcare providers, physicians like me and other clinicians, right? Because it's easier for patients to have a telehealth visit, it means that they're more able to comply with the healthcare plan, have their visits. I'm much more efficient. My visits stay more on time. And in fact, I can see more patients in a day using telehealth. Like any healthcare provider, I want my patients to be less stressed, more rested, happier to visit with me. And I think telehealth has allowed all of that. But let me be clear about one point. Telehealth is not a case of out with the old and in with the new. In visit office visits have immense value. In person, I'm able to do a much more thorough examination on the patient. I'm also able to pick up on clues, symptoms, and subtle signs, both from the patient and sometimes from the family member, that I might not really pick up on a telehealth visit. And beyond the clinical value, the in person visit, it has that intangible benefit. Being there in the same room with my patient, reading those nonverbal cues, picking up on their concerns, being able to reach over and put a reassuring hand on the patient's shoulder. All of these details matter, and really they're part of the building blocks of the physician patient relationship. So today's summit invites us to explore an intriguing question. We all know how telehealth works. How do we make telehealth policy work? How do we shape a system that gives patients options for both in person and telehealth visits? How do we protect their best interest? Not the insurance company, not the hospital, but the patient's best interest. How can telehealth maximize health outcomes and promote access to people who otherwise wouldn't have access to health care or specialty care? How can telehealth make the best use of healthcare resources? And most important to me, really uphold and keep at the center the physician patient relationship. To explore these questions, we've got a great lineup of speakers and panelists, and they'll be discussing how to strike the balance between in person and telehealth visits. What's telehealth's role in preventive care? What is the effect of telehealth on healthcare disparities? What about the rise of on demand virtual care? Most important, though, they'll be discussing the policy efforts underway today. These are what will determine the future of telehealth. So I look forward to these conversations and seeing your comments in the chat box. And please, please enter your questions through the question and answer feature on the live stream page. So with that, let's get started with today's program.
Traffic was always terrible, and because I have chronic migraine, I had to rely on a family member or rideshare app to get to my doctor's appointments. Then there was the waiting room, the bright fluorescent lights, the smell of other patients' perfumes. I was surrounded by all these triggers. Then came telehealth.
I struggled for years before I finally saw a doctor, got diagnosed with schizophrenia, then became stable. So I wasn't about to let my healthcare lapse when the pandemic hit. Virtual appointments and phone calls with my providers gave me flexibility. I could maintain care, stay up to date with my prescriptions, and keep living a healthy life. I still prefer seeing my doctors in person, but I like having telehealth options too.
At the height of the pandemic, my patients didn't have to choose between continuing treatment and risking exposure to COVID. Telehealth made that possible. The rate of missed appointments plummeted. It got easier for patients to visit their doctor. It even allowed providers like me to help more patients each day.
Telehealth lets me get treated from the comfort of my own home without having to worry about travel logistics and expenses.
Being able to call in, even if it's for 5 minutes, is life-saving.
My patients can make appointments without worrying about missing work, finding childcare, or navigating transportation issues.
So what does telehealth mean to me? It means receiving the best quality of care on my own terms.
Being able to touch base with my providers between in-person appointments.
Empowering patients with more options.
Millions of patients and healthcare providers benefit from access to telehealth. By crafting policies that balance telehealth access with in-person care, policymakers can make optimal patient-centered care a reality today and for years to come. Learn more at telehealthadvocates.org.
Thanks to Dr. Charles for those remarks and for setting the stage for today's discussions. You just watched a new video from the Coalition highlighting real stories of patients' and providers' experiences with telehealth. And we look forward to hearing more of those stories a bit later today. For today's first discussion, we'll explore the role of telehealth in preventive care. We've all heard it said that an ounce of prevention is worth a pound of cure. But what's the value of being able to access that preventive care through telehealth services? We'll consider how telehealth has increased access to preventive care for different patients and disease states, and how policy can ensure continued access to timely preventive care in the future. We will have time for Q&A at the end, so please put your questions into the Q&A box. I am joined by Kim Newlin, who is a cardiovascular clinical nurse specialist and is the immediate past president of the Preventive Cardiovascular Nurses Association. We also have with us Dr. David McSwain, Chief Medical Information Officer at the Medical University of South Carolina and an Associate Professor of Pediatric Critical Care Medicine. Kim and Dr. McSwain, thank you both for joining us.
Thank you.
So I want to get started here, really with both of you, but Dr. McSwain, we'll start with you. What has been the biggest impact you've seen regarding telehealth with the patients you serve?
Well, certainly there's been a shift in terms of telehealth adoption during the pandemic, but I think the bigger shift is actually towards the integration of telehealth services into the usual practice of clinical care. It's that change in the way that we're developing telehealth that is just a monumental and very important shift. It provides increased continuity of care for our patients, increased connection to families, improved communication, not only between providers and patients, but across different disciplines and between providers, integration into the electronic medical records, and a higher overall telehealth literacy level for everyone involved, which has really, I think, altered the course and the trajectory of the evolution of telehealth more than anything, more than just the overall adoption. By getting so many people engaged in telehealth and having them integrate it into their usual practice of care alongside in-person visits and other means of connecting with patients, that's what's really going to pay the biggest dividends down the line.
Certainly, we have gone from 0 to 60 very quickly. Kim, your thoughts on this, the biggest impact you've seen regarding telehealth with the patients you serve?
Yeah, so at my facility, I run our transition of care program, both as a nurse practitioner seeing patients in a high risk cardiovascular clinic, as well as our cardiac and pulmonary rehab programs. So we really couldn't stop these efforts to make sure that these patients had the right services and really were able to see the benefit of what we offered. And so we had to quickly switch to online and different programs using Zoom and visits through different apps. And so the biggest impact was really being able to touch the patients who we weren't able to touch before. So we have a large catchment basin of patients coming in with cardiovascular conditions. So we were actually able to extend our services and offer these to patients who weren't local and lived 20 to 30 miles away, not able to get here for many of the reasons listed by both Dr. Charles and in the video we just saw. So I think it's been interesting to have that. We also have in California some pretty bad air quality, which added to the pandemic, which made it difficult for these patients to get here. So it's been a fantastic shift for us, a little bit crazy at times, but willing to make the effort so we could extend our services to new patients.
That's interesting you mentioned the air quality, and just for those who are viewing, you live in Northern California where there have been a lot of wildfires, so I'm glad that you mentioned that. So Kim, I want to stay here with you. So tell us about how you've seen telehealth work well related to preventive care, specifically, for cardiovascular and cardiometabolic conditions. You kind of touched on it earlier, but I want you to elaborate on that for us.
Absolutely. So I'll focus a little bit on the nurse's role here. And we've known that telehealth in its primitive form, which was phone calls, has been effective with nurse case managers since the multi-fit trial out of Stanford in the 1980s, where we saw really great positive cardiovascular outcomes for patients having their risk factors modified and addressed after a myocardial infarction. So we've seen that data and the model really work well using nurse case management through phone calls and now extended to telehealth visits, both for primary prevention, just addressing risk factors and leveraging data you can pull out of your electronic health record, as well as in programs like cardiac rehab, where large healthcare organizations such as Kaiser, different academic centers have really been able to implement a home-based cardiac rehab program using nurses to do that case management and risk factor modification, as well as education and classes.
Dr. McSwain, share with us how over the last 18 months you saw telehealth work well for preventive care in a very different population that what Kim was working at. You're working with kids in the pediatric population.
Yeah, I think, the biggest impact was in those areas where you were able to integrate telehealth into the established provider's usual practice. And, this was especially important for well child visits in pediatric care. That's a cornerstone of pediatric primary care. And the other interesting thing that happened during the pandemic is because about half of pediatric visits are focused on acute care issues, most of which are infections, otitis media, other minor infections and injuries. Those really dropped off substantially during, especially the early stages of the pandemic, because of all the social distancing and protective measures in place. You weren't seeing the same kind of infections, the same kind of minor injuries, and so well child care became not only a critical component of that preventative aspect of pediatric care, but also a critical component of maintaining the practice for pediatrics during the height of the pandemic shutdown. So, you know, the thing with well child visits, though, is they have a specific list of things that should be accomplished at given intervals, at given ages, and not all of those things could be done virtually. But a lot of it could. A lot of what you do in pediatric well child visits is anticipatory guidance for parents and answering questions that parents have. And that's actually really well suited to a audio or audio video interaction. So it became incredibly important to do that. You had to work through some of the billing mechanisms, certainly, but pediatricians got very creative during this period and would do an audio video component of a telehealth visit to handle the anticipatory guidance, to answer questions, to administer surveys, even asynchronously, and then have a drive-through vaccination. Pediatricians were one of the earliest folks to do that in response to the pandemic, because they did it before the actual COVID vaccine came out. They would have parents drive their kids through their parking lot. They would have people set up out there to give them their MMR vaccine, their standard childhood immunizations. They would have folks out there to draw blood for necessary labs, or even do the important physical examination components that you can't do virtually. And the other really great development is that there was so much focus on the best practices in telehealth and virtual care that many organizations devoted a large amount of resources to making it function better. And the American Academy of Pediatrics is certainly one of those. They got a grant from HRSA to really integrate telehealth into community practice of pediatrics, and actually just released a very nice collection of resources that are focused on how do you integrate telehealth into your pediatric practice for various populations, especially those most at risk.
So, Dr. McSwain, sticking with you here, can you share some of the limitations, or where, pardon me, or where telehealth doesn't work as well in the pediatric population? Because we know it's not necessarily a one size fits all.
Yeah. Well, and as I mentioned, the things that absolutely require hands on, like vaccinations, like laboratory studies, certainly you have to have something other than just a remote approach there. And you have to work around those limitations. Another area that was a big challenge from the very beginning of this acceleration of telehealth was interpreter service and foreign language support for folks that maybe had disabilities and were not able to access the platforms effectively that were available to provide telehealth services. Prior to the pandemic, and even now still in many cases, foreign non-English speaking support was limited in a lot of telehealth platforms. And that is something that's being very actively addressed, something that needs to be a huge focus going forward. But I think, the key thing is telehealth is a tool. It's an array of tools, right? And you have to understand how to use it and how not to use it. And so the limitations are not necessarily completely set in stone. There are some aspects that certainly are, in terms of you can't give a shot virtually. But there are ways to work around those limitations and really change the way you practice to adjust for them and give yourself the greatest flexibility of how you want to provide services to your patients.
Interesting perspectives. So, I want to ask our audience our first poll question of the day. So, if you look on that live stream page, you're going to see a poll question pop up there. And it's a little bit to do with vaccines, which Dr. McSwain touched on. According to the World Health Organization and UNICEF, an estimated how many children worldwide likely did not receive a single vaccine in 2020. Four options. We have A, 11 million, B, 17 million, C, 20 million, and D, 23 million. So I've got a handy little tablet here that's going to show me real-time results of what we're coming in with. So we'll give that just a second here. And it looks like the real-time results, a majority of people are saying the answer is C, 20 million. Thankfully, it's B, 17 million, but that's still not good. It's less than 20 million, but it's still not good. So, Kim, same question that I just asked Dr. McSwain. We've heard where it works well. You talked about that. But when do you think in-person care might be a better option for cardiovascular patients?
Yeah, I think both Dr. Charles and Dr. McSwain touched on some of those times where you absolutely need that in-person conversation. I think in dealing with some of our aging patients, really when talking about goals of care, prognosis, maybe palliative care, I feel like that needs to be something that's done on an in-person basis. But that doesn't mean you can't use technology as a hybrid. I know we've had great experience with bringing in family members using technology and getting them on FaceTime or another app where that allows them to be part of the conversation with you having that conversation with the patient. I also know a lot of my older patients where technology is just such a stressful situation. If they either don't have resources at home to have a family member help them connect, just the thought of trying to engage via even a phone if they're hard of hearing or have other limitations is more stressful than it's worth. So I think that's definitely a patient population that you want to try to bring in. And of course, anybody with new symptoms that really requires a physical assessment.
So, Dr. McSwain and Kim, this is going to be the final question before we get to audience question A. So, Dr. McSwain, I'll start with you first. From a policy perspective, because we are at a policy summit today, what do you think policymakers can do to ensure that telehealth is used appropriately for these key preventive health measures that we've outlined today? Do you think perhaps medical societies or clinical guidelines might play a role?
Absolutely. And I think the key question that policymakers have to ask is how do you support that integrated hybrid approach to providing telehealth alongside and in collaboration and coordination with in-person services in a flexible way? Because obviously a big concern for payers is around utilization numbers and the risk of overutilization. If you have an integrated approach, um, especially with established care providers, that actually reduces the risk of overutilization of these services. And so I think there's benefits on both sides of the equation there. As far as the impact of medical societies and clinical guidelines, that's extremely important. And I work with the American Academy of Pediatrics. I chair their section on telehealth care. The way I became engaged with the AAP in this area was through the development of national pediatric telehealth guidelines. And the key point there is the professional medical societies, they're the ones with the medical expertise. You should pay attention to what those with the medical expertise are saying about the clinical aspect of providing telehealth services and are saying about how it could best be integrated into a coordinated approach with in-person care. The other aspect that's really important in terms of a policy perspective is that focus on equity and disparities. And we saw some somewhat unanticipated exacerbations of certain equity issues during the pandemic. And we really need to make sure that we have that important focus front and center in these discussions. And I think a key to that is research. We lead a lot of research on the pediatric side in telehealth, and research provides those objective answers to many of the questions around utilization and quality of care, safety. We have to support the research. We have to fund the research. We have to get our mechanisms to conduct it in place, and we have to guide the research by what are the questions most in need of answering from a policy and regulatory perspective.
Really great points there, and there is going to be so much data that we're going to be able to collect from the last 18 months to help inform that policy. So, Kim, we'll let you have the last word on this one from the policy perspective. What can policymakers do to ensure telehealth is used appropriately for these key preventive health measures?
Yeah, first and foremost, I echo what Dr. McSwain said. All of those are such key points. I think so. I'm on the board for Preventive Cardiovascular Nurses Association, and our advocacy committee is constantly looking into ways where nurses can and should be utilized for programs such as telehealth programs. We really encourage nurses to make sure they're publishing the research they're doing because, like Dr. McSwain said, that information and the data needs to get out there to really support and get into the guidelines. I think another thing that policymakers could address is just ensuring nurses and nurse practitioners and advanced practice nurses can practice to the top of their license so they can be included in these initiatives. When we look at providing care to rural and underserved communities, nurses often are in those communities and can provide that care. I think we also need to make sure that we're investing in the right technology to make sure that the access is available in more of our rural and outlying communities so they aren't left behind as we advance and integrate these hybrid models into kind of our day-to-day healthcare settings. So I think both, again, advocating for nurses, but also investing and making sure that the legislation that is being introduced into the House and Senate is evidence-based and can really make sure we're removing the barriers to providing telehealth to all.
Excellent points, Kim, and we're going to hear a little bit later from a member of Congress actually talking about the need for rural broadband access as it relates to telehealth. So we've gotten a couple of questions in from our audience, so I'm going to ask this one. Maybe Kim will ask you this one. How do telehealth services like remote monitoring allow people to get preventive care virtually? So maybe talk a little bit more about what remote monitoring is.
Yeah, so we have a lot of our patients who are already collecting data points at home and able to track their vital signs such as blood pressure and heart and exercise level, as well as maybe taking point of care testing. So for diabetes, getting their blood sugars. And so it's really allowing that data to be integrated into our decision making. So how do we get that information to our healthcare records, to the clinicians who are really making decisions and either adjusting medications based on that data, making recommendations, or ensuring that they get triaged to a higher level of care if you're seeing levels that are at an unsafe level. So a lot of people have a lot of access between our smartphones and different monitoring devices, but integrating those into the electronic health record has continued to be a challenge, and really having usable data and having the right people have access to it so we can use that data to provide the care.
Dr. McSwain, here's another question. This is obviously maybe a patient or advocate. They say sometimes when I go to the doctor, the problem seems like it's already gone too far. How can I make preventive care work for me?
Yeah, I think it's maintaining that close level of contact with your provider, with the care team, not just the physician. You know, as Kim was saying, it's important. There are a number of care team members that participate, especially in more chronic or complex conditions. And so anything that we can do to improve that communication and that connection and that sharing of information across providers and across systems is incredibly important. And so, and telehealth is simply one of the tools that allows us to do that effectively.
Great. Well, that's all the time that we have for today. So, Dr. McSwain and Kim, thank you so much for joining us, for sharing your very valuable insights with us. We appreciate you sharing your day with us.
Thank you very much.
Thank you for having us.
Throughout the day, we are going to hear from patients and providers who will share their experiences with telehealth. For our first patient perspective, I'm pleased to introduce Matt Connolly, coming to us from Des Moines, Iowa. Matt is a passionate mental health advocate who will share his thoughts and experiences about telehealth. Matt, the floor is yours.
Morning. I come to you today as someone who fills many roles. I'm a father, a husband, a real estate broker, a mental health advocate, and yes, a patient. Telehealth has helped me in each of these roles. Flexibility, being able to talk or visit with my providers over a phone or laptop, has meant less time in traffic and more time for other obligations, meetings, family dinners, being able to hug my son and daughter before they leave for school, or read them a bedtime story at night. It's meant that I have options when a work, community, or family engagement arises. I don't have to carve out a chunk of my day just to make a medical appointment. I get my time back. And all the while, I'm staying on top of my health. That's important because I live with schizophrenia. You see, it took me years to finally see a doctor, get a diagnosis, and become stable. I fought hard to get where I am today, and I'm not about to let that progress go. The benefits of telehealth became obvious to me during the pandemic. Like many of you, I discovered telehealth to be a lifeline. Even as COVID was disrupting nearly every aspect of normal life, I could talk things through with my doctor, I could stay current with my medications. In fact, sometimes it felt like good old days when you could just call your doctor. But as we look forward to a time when the pandemic, we hope, becomes a thing of the past, I'm also excited to see my providers in person again. In fact, in-person visits are my personal preference. So I guess it comes down to this. I like having options. And I know I'm not alone on that point. If we've learned anything from the pandemic, it's that not everything is an either or proposition. Telehealth certainly shouldn't be. Today we look around and see hybrid workplaces and hybrid schools, people mixing in person with virtual every day. All across society, we've moved beyond the point where people have to choose one or the other. There's no reason healthcare shouldn't evolve in the same way. Here's how I see it. Nothing can ever replace in-person care. People seeing their provider, sitting across from them, having an in-person exam, or a focused conversation there together in the same room. But telehealth plays a critical role too. So let's move forward with policies that give patients options. That allows providers to use virtual appointments to complement in-person visits in a way that works best for each unique patient. For people living with mental health conditions, the stakes are high. Timely care, preventative care, and adherence to medication routines can make a drastic difference in health and in quality of life. For us and for all patients, telehealth and in-person visits are both important parts of quality care. Let's work to keep it that way. Thank you.
Thank you so much, Matt, for sharing your telehealth perspective with us. Today's keynote speaker is Congresswoman Marionette Miller Meeks, a physician and former director of the Iowa Department of Public Health. She currently represents Iowa's 2nd District in Congress. And last week, I had a chance to talk with her about the importance of rural broadband access and telehealth. Here's my conversation with Congresswoman Miller Meeks. Congresswoman, thank you so much for joining us today.
It's a pleasure to be with you, and also to all of you there at the summit. And I apologize that I can't be there in person, and instead we're relegated to virtual, but perhaps that's actually a good thing given the topic that we're discussing.
It is, and we know Congress is very busy, so thank you so much for taking the time. So I want to get right into it. You recently wrote in an op-ed that while 97% of Americans in urban areas have high-speed fixed internet services, that number drops pretty significantly to about 65% in rural America. And in fact, you called that unacceptable. So can you talk to us a little bit more about this gap in access that many rural Americans are facing, and maybe even specifically to a lot of your constituents in the rural state of Iowa?
Yes, certainly. So my congressional district is basically all of Southeast Iowa if you cut our state into quarters. And so even as a state senator, I was very active in trying to get broadband to rural areas. So we knew that that was an issue before. In the state senate, I lovingly called it, please get Dr. Miller Meeks better internet access so her children will come home more often. And that's because just trying to download physician articles, which is what I was doing, articles or doing online continuing medical education credits, it was a challenge to be able to do that and have connectivity. And if the weather was bad or there was a cloud in the sky, connectivity would evaporate. And so I felt if that was true for me, as I discussed with my constituents, it was true for a lot of us in rural Iowa and rural areas. So I was very active on this front in the state senate. And then lo and behold, we have a pandemic. And the pandemic has really underscored the need for better broadband access for a variety of reasons. So one of the first things I did when our legislature went into a pause was to talk to our leadership and our governor about expanding telehealth. So having all insurance companies cover telehealth and also having parity for telemedicine or telehealth. And so it's a very important issue as we saw through the pandemic. The necessity of connectivity was crucial when we were isolating people into their homes or having them work from home and isolating them from other human beings. And we know that that's been a tremendous cost and sacrifice for a great many people. So whether it's telehealth and the ability to communicate with a provider, with a physician, especially given the workforce issues we have in rural America and rural Iowa, be it education, K through 12 education, and even college education with online courses, getting access to educational opportunities in rural areas that you would not have because you just don't have either the facility or the revenue to bring in specialists in a lot of different areas. So bringing in AP courses or art or music. So expanding that horizon of the educational opportunities for individuals in small schools for our students, that's important. And then we also look at telework. So between telework, telelearning, and then telehealth, I think the emphasis on broadband and underscoring how important broadband was to enable us to connect was important. The other thing that's interesting is that telehealth is not a new concept. So we've been trying to do this. We've talked about this. As a director of public health, I was interested in trying to move this forward and had met with various groups. But the technology wasn't quite where it is today. So as the pandemic hit, our need for telehealth increased. The technology had also accelerated. So video imaging, if you think about that, getting people together on a phone line together is one thing. So you could do some, counseling, some psychiatric or psychological services, but to send images so you could actually do care and then add to that artificial intelligence and how the three of those things will mesh together. I think that the pandemic came at a time when technology was such that it made remote learning, remote work, and remote medicine possible.
Yeah, so long as really we have access to the broadband, as you just mentioned, and it cuts across, as you say, it's not just about telehealth and telemedicine, it's also teleworking and it's educational opportunity. So we know that this access is key. So tell us a little bit about what you and your colleagues in Congress are doing to close this gap in broadband access in rural America.
There are several bills in Congress from both sides of the aisle on the broadband issue and also on the telehealth issue. So on the telehealth issue, we certainly have sent letters, and there are bills on parity, expanding access, both in the healthcare system and in the VA system, because it has its own rules and regulations. So the expansion of telehealth, but also then in expanding broadband and broadband access. So within the COVID-19 packages, there was money that was expended and appropriated or allocated for increasing broadband access. The state of Iowa has certainly done that. And Governor Reynolds had recently, she's the governor of Iowa, had recently indicated putting an additional $100 million in for broadband and rural broadband in the state of Iowa and increasing upload and download speeds. I'm also a co-sponsor of HR 4437, which is helping ensure access to local telehealth, or the Health Act. Sponsor of HR 366, which is protecting access to post-COVID-19 Telehealth Act. And then I'm a member of the Healthy Futures Task Force. So we're looking at this both in the modernization of healthcare. So not only in expanding telemedicine and telehealth, which part of that, as we said, is broadband access, but it's also in how we use technology to improve our health. So we really have, I think, great opportunities as we look at our entire healthcare system for using, broadband internet access, telehealth, but then also using personal wearable devices or technological devices, if you will. And that's going to require broadband access and internet access.
So I'm interested to hear from your perspective on this, because some people may not know that you, in fact, are a physician. You're an ophthalmologist, so very, very specialized. I want to ask you how lack of broadband access can unfortunately exacerbate some health inequities and disparities that currently exist.
Well, I'm so glad that you brought up that topic. It's critically important. So we think, and because I'm in a rural state, we talk about broadband access and we talk about rural, but some of the regulatory changes that we had to make within our state is that access to high-speed internet in one location doesn't mean the person next door has access to high-speed internet. So you can have gaps in service, and so that means low-income individuals, minority communities may not have access to internet services. And especially during the pandemic, when schools were closed, this was a huge barrier to learning. It was a huge barrier to access to medical services, and also a barrier to work. So, for those opportunities that we want all of our children to have, all of our citizens to have, I think access to high-speed internet, and we know satellite is a portion of that, but cable, I think, and broadband is where we need to go. Making sure that everybody in a community, that just because 2 blocks away there's high-speed internet, that does not mean that there is, access to high-speed internet for everybody within that community. So we need to make sure that it is pervasive, that people have the opportunity, that we get to that, not only the rural areas and that last dollar mile, but that even within large cities and urban areas, that there is access to all individuals, which, as I said, necessary for both learning, work, and health.
Yeah. And certainly when it comes to telehealth, that's why a lot of advocates are also pushing, for good coverage of audio only visits, because we do know that these gaps in broadband do occur. So, Congresswoman.
Part of it, and if I could add, one of the bills I passed as a state senator was a bill to allow schools as a site of service for telehealth visits for behavioral health and mental health. So, looking at transportation, it's not just whether you have the ability to have it, but it also helps facilitate those in low income areas or in rural areas who lack the transportation to get to a visit. So that's another area where I think having access to broadband is extremely helpful in ensuring compliance with provider visits and access to care.
Absolutely. So, what are you hearing? I'm just curious more generally from your constituents about telehealth.
So far, the reviews have been very positive. And I think, again, it's a combination of things. When we started doing this 10 or 15 years ago, and it's not unusual for doctors to call patients. And when I do surgery, I call my patients the night of surgery. Almost, I'm not going to say 100%. I'd be caught in a web. But probably better than 95% of the time, I would call my patients at night to see how they were doing. And a lot of that was to address the issues we just talked about: transportation, something happening late at night, someone not having access to a phone service. So I would just call individuals to make sure my patients were doing okay and not experience any problems or difficulties. And so, this extension of that, as we look at how do we provide telehealth, how do we provide access to broadband access, and with the imaging capacity, the speeds, the audio capacity being better, at technology at a place where right now it's almost as good as being face to face. So that comments I have received from people, both providers, once they were able to set up the system, to get it working, to try to get good connectivity, both on the provider side and on the patient side, it has been extremely well received.
Yeah, I've heard a couple of anecdotes from patients who actually feel like this harkens back to a different generation when you could just call up your doctor and they could swing by your house and do an examination. So it's really sort of telehealth is really given a new perspective, I guess, on that physician patient relationship, which is fantastic.
It's almost like having a home visit.
Yeah, exactly. Exactly. Okay, so Congresswoman, this is my last question for you. There's a lot going on in Congress right now, but you've got a captive audience in front of you today. So, what can we as clinicians, advocates, healthcare providers, patients do to help make rural broadband access a reality for the millions of Americans who currently don't have it?
So I would say to continue doing what you're doing. Nothing moves people in Congress more than hearing from their constituents. So you as a group of individuals, and then you as individuals who are represented by your congresspeople and your federal senators. So being active, being engaged, you are the voice for so many people for your patients, and you can bring that voice to Washington D.C. But this doesn't exclude the state level either. So there are interactions and interchanges on both the state and federal level. There is dual funding. So being active on both the state and federal level, knowing that you're the voice for so many people to get access to care, access to broadband, the reimbursement levels for telehealth and telemedicine, I think is critically important. So what you're doing is greatly appreciated. I would say keep it up both on the state and federal level, and then have your patients who have a good story. Make sure that story gets told. Tell their story and relay that on to your congressional advocates, because nothing moves minds like hearts.
That's exactly right. Well, Congresswoman, thank you so much for joining us today. Thank you for all of your work in highlighting the need for rural broadband access to millions of Americans. We don't want to forget about those who don't have access to it, and we want to make sure that they can receive optimal care like people in urban America. So, Congresswoman, thank you so much for joining us today, and best of luck as things shake out in Congress.
Thank you so much. You all have a great rest of your summit, and I enjoyed being with you, even though it was virtually.
Thank you. We want to thank Congresswoman Miller Meeks for taking time out of her very busy schedule to talk with us about access to rural broadband and the impact that that will have on patients accessing telehealth. We are now going to pause for a short break and we will return at 12:30 Eastern Time.
Good afternoon and welcome back. I'm Amanda Conshafter from the Alliance for Patient Access, and I'm pleased to kick off the second half of today's summit with a discussion on state and federal telehealth policy. This discussion will get us up to date on which policies will shape the future of telehealth, where those conversations are headed, and what policymakers can do to protect the benefits of telehealth for years to come. To explore this topic, I'm pleased to welcome Jack Pitzer from the National Conference of State Legislatures. Jack, welcome.
Hello, thanks for having me today.
Let's start with the issue of parity. So this is the critical question of whether health plans treat virtual appointments the same way they do in-person appointments. So Jack, why is this issue important for telehealth access? And what trends do we see in policies being enacted in the states?
Yes, so payment parity has been a very large discussion in the states for both private insurance payers and for state Medicaid programs. But first, for just a little bit of level setting, so payment parity generally means that reimbursements for telehealth are on the same basis or at the same rate as in-person services. And proponents of payment parity argue that this is a really important incentive because telehealth technologies can be expensive. And if reimbursements for telehealth are lower than they would be for in-person services, that may be a really big barrier for providers to adopt telehealth. And this is especially true for smaller providers or providers that are working within underserved communities. On the flip side, some argue that telehealth may not always be equivalent to in-person care, and that yes, telehealth has the opportunity to deliver services at a lower cost, but then if you require payment be the same as in-person services, you may negate those cost savings. So with all these different considerations, states have really been trying to nail down what reimbursement for telehealth should look like. And we at the National Conference of State Legislatures released a telehealth toolkit for state legislators back in July of this year. And as part of that toolkit, we looked at the private insurance laws across all 50 states and DC for telehealth and found that 22 states mandate payment parity. An interesting trend that has also popped up this year are states that mandate payment parity, but for specific health services. So Massachusetts was the first state to do this year when they required payment parity for telemental health, and they're temporarily requiring it for chronic disease management services and primary care services. And then Iowa, Nebraska, and Rhode Island also mandated payment parity this year for telemental health, and then Rhode Island also requires it for dietetic services and primary care. And then on the Medicaid side of things, a lot of state Medicaid programs implemented payment parity in response to COVID and are looking to potentially permanently incorporate these payment parity requirements beyond the PHE. So New Hampshire enacted legislation to do so back in June of 2022, and California is looking at permanently requiring it for live video and then differentiating reimbursement for different methods of telehealth like audio-only telephone consultations.
Great, thank you for that response. And to our audience, a link to the toolkit that Jack mentioned should be available in our chat box, so feel free to check that out. Now, one tricky issue, Jack, when it comes to telehealth has been this question of state boundaries. So we know that a major benefit of telehealth is allowing patients to see specialists who might otherwise be geographically out of reach for them. We also know that with the rise of virtual workplaces, patients might be moving either permanently or temporarily and may find themselves in a state other than their home state when they need medical care. So walk us through the issues here. Can a provider treat a patient who's in a different state? Can a provider prescribe medications for that patient across state lines?
Yes. The easy answer is it depends. It depends on which state, which type of provider is delivering services, where the patient may be located, whether there's requirements around an existing provider-patient relationship, and a whole host of other factors. But this discussion of trying to streamline licensing requirements for out-of-state providers has long been something states have been looking at, particularly within the context of mitigating healthcare workforce shortages. And there are a whole bunch of different ways states have been pursuing telehealth across state lines. One of the more common strategies are for states to adopt interstate licensure compacts for specific provider types. There are currently 6 licensure compacts for different providers like nurses, physicians, and psychologists. And the way that this works is that states enact specific legislation to join the compact, and then providers that meet the unique needs and requirements for that licensure compact are then able to deliver services to other member state residents in other member states, including via telehealth. Beyond licensure compacts, there are some states that have been taking a much more expansive approach. Of note is Arizona, Florida, and West Virginia, where these states enacted legislation to pretty much allow every single type of, or many types of licensed providers to deliver services to in-state residents. And these providers must register with a state Department of Health or other state agency and then agree to other requirements such as not setting up a practice within that state. And then on the prescribing front, that is an incredibly complicated topic area with a whole bunch of different federal and state requirements. But I'd say generally there are more safeguards and requirements in place for e-prescribing. So most states do require an in-person consultation prior to prescribing via telehealth, particularly for controlled substances. And in the states like West Virginia, for example, where they really have been trying to streamline licensing requirements for out-of-state providers, they do not allow these out-of-state providers to prescribe Schedule 2 or Schedule 5 prescription drugs via telehealth, even if they are authorized to do so in their own states.
All right, well, last question. What regional trends, if any, do you see as state bills emerge? Does it seem as though maybe certain areas of the country feel differently about different aspects of telehealth policy?
Yeah, that's a really interesting question. And my initial reaction is that changes to telehealth policy have been widespread across the United States, regardless of region or geographical area. So as part of that telehealth toolkit that I mentioned, we tracked at least 51 enacted bills across 37 states that permanently incorporate some sort of COVID-related telehealth flexibility into state law beyond the public health emergency. And that is a huge number of bills across a very large number of states, and they touch on many different topic areas like private insurance, Medicaid, cross-state licensing, which providers are authorized to deliver telehealth services, you name it. But if I were to try to nail down on some geographical trends, I'll say states with more rural populations are really looking for specific strategies to try to increase access to services in these areas. So a lot of states have enacted legislation to increase access to audio-only telephone consultations, and policymakers see this as a really important way to increase access to telehealth in areas with poor broadband connectivity. Then there are a lot of rural states that have also tried to increase access to telehealth and reimbursement for telehealth for federally qualified health centers and rural health clinics. And then I'd say this conversation of streamlining cross-state licensing also fits within this bucket of actualizing telehealth's benefits within rural communities. But generally, I'd say policymakers in pretty much every single state have been looking for ways to expand access to telehealth for their constituents.
Good. Well, that's great to hear. Well, Jack, thank you. Thank you again for your time. We appreciate your joining us today.
Yes, thank you so much.
So now we'll take a moment to poll our audience once again. And here's the poll question. In your opinion, which of the following telehealth capabilities is most important to patients? Is it A, having equal access to both virtual and in-person appointments? B, being able to access a provider virtually regardless of state lines. C, being able to have a virtual appointment from home or work. Or D, being able to access a specialist who would otherwise be geographically out of reach. So take a moment to log your answer, and I'll take a look at our results. So we'll give it just a minute. All right, so it looks like about half of our audience says D, being able to access a specialist who would otherwise be geographically out of reach is the foremost benefit that matters to patients. So thank you for that. All right, well now prior to today's summit, I had an opportunity to talk with Kyle Zebley of the American Telemedicine Association to discuss a few key issues that impact telehealth policy. Let's take a moment now to look at that conversation.
Well, hello, Kyle. It's nice to see you today. Thank you for taking the time to talk with us.
Good morning. It's so great to be here. Thanks so much.
So, Kyle, there are a range of policy issues to discuss when it comes to telehealth, but I want to focus on three that I know are of interest to our audience and also a focus of your association's work. So, let's start with the question of providers. So, for patients, access to telehealth may sometimes hinge on the question of which healthcare providers are approved to offer telehealth services. So, can you tell us, please, which providers have traditionally been associated with telehealth? How has that list maybe changed during the pandemic? And then what can we expect moving forward?
Thanks so much. Great question. So, in terms of providers that have traditionally covered telehealth, I think that would largely be considered to have been physicians. And obviously, there has long been pressure to open that up, to allow for more providers, other medical professionals to be able to deliver healthcare services. But the reimbursement really wasn't there. And in truth, the reimbursement, even for physicians, had really lagged behind where the technology was. And so, what happened in the early days of the pandemic was that restrictions on providers getting reimbursed, including physicians, really came tumbling down. Geographic and originating site restrictions, really most notably. And also the subset of providers, the broader areas of medical professionals to include a variety of therapists and nurse practitioners, also finally had a chance to begin having reimbursement for the services that they were able to provide via telehealth. I think that, like with physicians, this broader provider population is never going to go back to the way things were prior to the pandemic. I think we're going to continue to see that telehealth is here to stay, that those restrictions, some of which may have been temporarily lifted during the pandemic and during this public health emergency federally and incomparable temporary actions at the state level. We're seeing at the state level those becoming permanent policy to expand those providers that can deliver telehealth services. And then at the federal level, we still see that broader category of providers being able to be covered because the PHE continues to be in effect. I think that it's safe to assume that in future we're going to see an extension and hopefully a permanency for allowing for them to provide and get reimbursed for services via telehealth.
Great. Well, that's good to hear. Thank you for the response. So you mentioned origination sites briefly, and that's really the focus of my next question. So where must a patient be physically to meet the coverage requirements for a telehealth visit? Can you walk us through that issue?
So really most notably, and something that takes up so much of our time at the federal side of things, in terms of the Medicare program, historically, you had to, because of a law passed in 1997, Section 1834M of the Social Security Act, you had to be in a defined rural area outside of a major metropolitan area. And you had to physically have gotten in some mode of transportation and headed to a provider's office, a Medicare provider's office, in order to have reimbursable telehealth. And when I tell folks that now, I think usually their heads spin. They cannot believe that the law could be so outdated and have not kept up with technology. And so consequently, because of this action passed 24 years ago, before the pandemic, there was really only a tiny sliver of Medicare beneficiaries that were able to actually access telehealth and have their providers reimbursed for it. In the early days of the pandemic, policymakers who undoubtedly were reading policy briefs that we had been putting out for years, and other organizations and advocates for telehealth had been saying for years, really knew where the pinch points were if they were seeking to increase access to care and keep people at home. And so what happened was that these Section 1834M restrictions were lifted. And as it stands now, because they're still lifted, because the public health emergency is still in effect, Medicare beneficiaries are able to access virtual care where and when they need it, including in their own home or wherever they might be in the course of their day when they're having a virtual encounter with a Medicare provider. So that's one of the big drawbacks. There are lots of statutes in place, many of which have been lifted in the intervening 18 months, that had similar restrictions on what would count as an originating site, for instance, in Medicaid and commercial insurance. And so hopefully they'll follow Medicare's lead as we fight to make sure that those 1834M restrictions don't come back if the public health emergency does eventually end. And that will set us up for a situation that we call at the American Telemedicine Association the telehealth cliff, where all of a sudden Medicare beneficiaries who have access to care now, where and when they need it, will go back to a very tiny subset of the overall beneficiary population. And what we find would be really unacceptable. So Congress has to act before the public health emergency ends to keep these flexibilities permanently in place.
Okay, got it. Thank you. So now I'd like to touch briefly on different types of coverage and different types of telehealth services. So whether that's synchronous, the real-time interaction between a patient and a healthcare provider, or remote monitoring, or perhaps asynchronous, store and forward type uses, how do the rules differ here?
So at the federal level, again, talking about the Medicare program, quite significantly, for reasons good and bad. Those 1834M restrictions that I just mentioned that really put originating site and geographic restrictions on in terms of virtual care, that actually is only applicable to synchronous audiovisual telehealth. So that's an important consideration when we think, for instance, remote patient monitoring or remote monitoring. That is considered a different portion of the federal code, and that's able to be covered regardless of your geographic location originating site. It hadn't been covered in the Medicare program through its physician fee schedule, which is how Medicare determines what, through Medicare fee for service Part B, what a provider will get reimbursed for, at what level, what is covered, and what the cost will be for the provider that they can bill Medicare. That continues to allow for providers to offer remote monitoring technology no matter when the public health emergency is. Again, in Medicare, if we're thinking asynchronous, there is very little of asynchronous care that is not remote monitoring care that is covered. So that's a really important consideration. At the state level, this is where the practice of medicine, those kinds of decisions are really made. And that's where decisions around what Medicaid agencies at the state level will and will not cover, and what commercial insurance has to cover. And so what we've really seen over the last several years, particularly after COVID-19, was that increasingly states are adopting what we find to be telehealth-friendly, modality-neutral policies that removed restrictions that had been in place for providers making decisions as to what modality to use or not use according to their best clinical judgment when interacting with a patient. And so we're increasingly seeing old restrictions on asynchronous telehealth, on audio-only telehealth to include phone calls, but not strictly limited to phone calls, and also to remote monitoring technology. We're seeing those restrictions come down, and we think that's a really positive direction. And obviously, as with all of these items that I've discussed, it's really moved forward in leaps and bounds in terms of the greatest flexibility for providers in choosing what appropriate modality to use in the best interest of their patient.
Great. All right. Well, my last question for you, and I know we have just a few minutes left, but we know that telehealth offers benefits to all patients, and certainly, but certain groups, it seems, maybe have more to gain than others. So I'm thinking specifically of underserved communities, at-risk populations, older Americans. Why is telehealth so critical for these groups, and what policies do we need to serve these patients best?
Well, you're absolutely right. Telehealth is for everybody. Telehealth is healthcare. It's not something separate and apart than the rest of the healthcare system. It's just another way in which providers can deliver care to patients. But you're right. There are certain populations, underserved communities in rural America, in urban America, and yes, even in suburban America, that had lacked access to care for decades for a variety of reasons because of systemic issues, oftentimes, with the US healthcare system that simply had not been delivering quality care at an appropriate cost for millions of Americans who have been left behind. Now, of course, telehealth didn't cause these inequities, hadn't led to Americans being underserved in terms of healthcare services. But we're very confident that it is now a tool to address and mitigate these disparities. And we know this because of the fact that we have an ever-growing U.S. Population and an ever older U.S. population, a U.S. population with increasing degrees of comorbidities and non-communicable diseases, coupled with an increasing provider shortage of all stripes. So how are we going to maximize the limited resources that the U.S. healthcare system has now and in the years to come without utilizing the efficient tools of telehealth? There's simply no other way to do it. And so if we're going to continue to make sure that Americans that didn't have access to care gain access, we need to target those restrictions on virtual care in federal programs and in state laws in order to make sure that all Americans can benefit from virtual care. That means that we have to have, of course, sufficient level of broadband connectivity in order to make sure that Americans of all stripes can have access to all the various modalities of virtual care. But it doesn't end there. We have to make sure that there's education in place, that the Americans have access to devices that can take advantage of virtual care, that outdated restrictions on originating site, geographic location are removed, and that payers, both public payers like Medicare and Medicaid and the Indian Health Service and TRICARE for our active duty military personnel and Veterans Administration through federally qualified health centers and rural health clinics, that they're all able to cover and get reimbursed for virtual care in a permanent way, moving past the end of the PHE, and that state Medicaid agencies and commercial payers are covering telehealth services to the same degree that they would cover them if they were in person. If we target these policy blockages, then I think that we'll continue to have this dream of Americans having access to care where and when they want it. And again, I don't think you can ensure Americans have access to that care without having telehealth as an option for them.
Great. Well, Kyle, thank you for those insights, and thank you for sharing your time with us today. We appreciate it.
So great to be here. Thanks so much.
Thanks again to Kyle for that interview. So now we'll turn our attention to the question of balance. Telehealth offers significant benefits, but few patients or providers are ready to walk away from in-person care. So how do we find the right combination of access and coverage for people who want the best of both worlds? To explore the topic, I'm pleased to welcome Stacy Worthy, counsel to the AIMD Alliance, and Ted Thompson, who's Senior Vice President of Public Policy for the Michael J. Fox Foundation for Parkinson's Research. Welcome to you both. We've allotted time at the end for questions, so feel free to our audience members to enter those in the Q&A box during the discussion. So, Stacy, I'd like to begin with you. I know that the AIMED Alliance recently hosted a meeting of representatives from across the healthcare and advocacy communities to take a closer look at what telehealth means to patients, providers, and advocates. So, thinking back on that meeting, what were the benefits of telehealth that came through most clearly to you?
Absolutely. So there were quite a few benefits. People said that it allows providers to reach more patients, it promotes health equity, and reduces stigma. So, for example, during the pandemic, it allowed for continuity of care to reduce negative consequences in at risk and underserved populations disproportionately affected by COVID 19. It's also a benefit to patients in rural areas or in areas where there are no specialists nearby, and for those who may have long commutes, are not mobile, lack transportation or childcare, or can't take time off of work. They also said it reduces stigma among individuals who have faced historical discrimination, including those with substance use disorder or mental health conditions who may be embarrassed to seek treatment in person. And then also helps prevent spread of infectious diseases such as COVID-19 or even the flu. They did mention some drawbacks though. So, for example, they said, it does not allow providers to examine the patient. So, it may not be suitable for diagnoses that require a more hands on approach. They also said providers may miss symptoms that might be noticeable during an in person care, which can compromise care. And also, while telehealth can address some health disparities, it can also lead to others. So, for example, we heard that certain patients can't use it, such as those who live in areas without access to broadband internet, who lack access to required technology, who just aren't computer literate or tech savvy. And sometimes there's a generational difference there.
That's interesting. Thank you, Stacy, for that response. So, Ted, I'll turn it to you now. So, Stacy outlined some of the benefits of telehealth access across a broad population, but I'm curious to hear from you. Which of those benefits are most valuable to people living with Parkinson's? I think to some people, telehealth may not seem like a natural fit for Parkinson's because a hallmark symptom of the disease is a disruption in movement. But how is it that telehealth benefits people living with Parkinson's?
Thank you for the question. Thanks for having me. That disruption of movement is actually one of the primary benefits of it. Parkinson's disease is a movement disorder, and oftentimes patients have difficulty getting to and from appointments. That's amplified by the fact that there's a real shortage of neurologists in this country, and in particular, movement disorder specialists that are the preferred doctor for Parkinson's patients to see. So telemedicine has provided a tremendous opportunity for the Parkinson's patient to get the care they need when they need it. One of the other benefits, which is somewhat counter to the comment Stacy just made, was that for Parkinson's patients, one of the things that doctors can't see that can be very informative for the care plan is where a person lives. And through telemedicine, a patient can show the physician or other health provider what their living situation is and whether they have appropriate distance between furniture or handicap accessible living facilities and things like that. So that's a slightly different benefit, but it's a very important benefit. Finally, one thing I want to mention was we've heard a number of stories from patients that have said, prior to the pandemic, I had never seen a movement disorder specialist. I never was able to see a doctor that knows much about Parkinson's. But because of the pandemic, they were able to finally access the specialists they need and were able to alter their medications and other care and have seen a marked improvement in the quality of life for living with the disease.
Well, that's great to hear. So, one issue I want to ask about, people generally have opinions on this, is the use of audio only telehealth visits. So, this is a virtual visit minus the video component where a patient is just talking with a provider over the telephone. So some people say, yes, this is a critical missing link for some patient populations. It's the only way certain patients can or will connect with their doctors. But others say, no, it's just not enough to count as a clinical visit with a healthcare provider. So Stacey, what do you hear from the health advocacy community on this topic?
We hear both sides. So, some patients who live in the areas with a provider shortage or otherwise can't get into a doctor's office are also the same patients who lack access to broadband, internet, or video technology. And so, audio only allows them to still receive the care they need. However, at the same time, audio only obviously doesn't allow the healthcare provider to see the patient, and the provider may not be able to offer a complete or thorough examination without being able to see and assess those visual cues. Also, we've heard that some policymakers are concerned that covering audio only services may result in unnecessary overutilization of telehealth, which could drive up program costs. And some have also proposed that if you're using audio only, that it should be restricted only to those people who truly need it, and potentially combined with an in-person requirement. For example, being treated in person within 6 months of that audio visit.
So Ted, what about you? You mentioned earlier, and I thought it was interesting that video visits can allow providers to take a look inside of patients' homes and to advise on living conditions, but is audio only an important tool for people living with Parkinson's disease too?
Oh, absolutely. And for example, one of the reasons would be medication adjustments. I don't think you would necessarily need to see the patient in order to advise on an adjustment to a medication. So I think that's one element. And the other, was just mentioned that there are wide swaths of this country where people don't have access to broadband. They don't have the equipment. It's a health equity and disparity issue. So audio only isn't a singular solution, but we do think it's one of the tools in the toolkits that needs to be available for patients and providers.
For sure. So a different topic now, an important facet of the discussion about balance is the question of who has the decision-making power. So Stacey, let me start with you. Who decides when a visit should be virtual and when it should be in person? And who should decide? And how do coverage issues influence that decision?
Yeah, so currently, either the patient or the provider can decide that the visit should be virtual. It's based on patient preference, whether the provider offers telehealth as an option, and provider's clinical assessment of whether virtual visit is appropriate. On the flip side, if either the patient determines that in-person is preferred or the provider deems it necessary, then it should be an in-person visit. Regarding coverage, it can definitely influence a patient or provider's decision. Under some plans and in certain circumstances, telehealth appointments are free, so patients may be incentivized to choose telehealth for that reason. So, for example, last year, Congress passed the CARES Act to address COVID-19, and that allows private high deductible health plans to make an exception for patient cost sharing related to telehealth. And that means that up until December 31st of this year, these plans can now cover telehealth visits with no cost sharing or limited cost sharing, even if the patient hasn't met his or her deductible. And that protection can be expanded past December likewise. If you have patients who need care but they can't afford their copay, that's an option for them. Likewise, if a provider is reimbursed at the same rate for telehealth or a higher rate, then the provider may prefer telehealth too, because the provider may be able to see more patients in a day using telehealth than if they were to have all in-person visits, because in-person visits can be more time consuming. Again, on the flip side, if the plan does not cover telehealth adequately or at all, then both the provider and the patient are going to be incentivized to do an in-person visit. And unfortunately, in some instances where the patient can't do an in-person visit, they may just decide to forego treatment altogether.
So, Ted, a related question for you. How much autonomy do patients have, or should they have? So, say, for example, a patient is doing fine but hasn't seen the doctor in person for over a year. Is an in person visit warranted? And what are the considerations that play into decisions like these?
That's a good question, and I'm not a physician, and so I'm going to preface this by saying that obviously this is a decision that should be made jointly by the physician and the patient, or if the physician truly believes an in-person visit is needed, that they arrange for that to happen. Um, we've got roughly 90% of our population are on Medicare. And so the expansion of telehealth under Medicare, was critical. And we had done a survey through our Fox Insight survey platform that earlier on in the pandemic that showed that 62% of Parkinson's patients were having problems accessing care. And I think it was 39% of them then turned to telemedicine, telehealth, to be able to reach out to their doctor and have the visit that's necessary. So in terms of, is there a need for an annual in-person, things like that, I would defer to the physician to make that determination.
Sure. Well, Stacy, a question for you. We know that policy issues, separate from questions of patient preference or decisions made between the patient and the clinician, the policy issues can have an impact too. So, from a policy perspective, what roles do issues like physician reimbursement, patient cost sharing, or even clinical guidelines play in finding that balance between in person and virtual care?
Yeah, so policy issues definitely play a role in choosing one or the other. So currently, I think some of this may have been already addressed earlier, but there's a patchwork of state laws governing telehealth coverage and reimbursement, and it results in better access to telehealth in some states over others. So, for example, at least 43 states and DC currently have parity laws in which private payers must cover telehealth services similar to in person visits. On the other hand, some states have a lot of limitations, such as limits on the type of providers that can offer telehealth services, where the patient is physically located, and whether the provider can treat patients across state lines. Many of these restrictions were eased during the pandemic, though, so it makes access to telehealth more robust. Also, historically, Medicare has imposed several restrictions as well. So, for example, they haven't allowed audio only telehealth. They restricted coverage to those who live in rural areas. They don't allow for practicing cross state lines. And they don't allow, or they hadn't allowed patients to access telehealth from home. A lot of that changed during the pandemic, and the federal government eased many of those restrictions. To make these flexibilities permanent, federal legislators are going or have they've introduced over 40 bills this year. However, none of those bills currently include language to specifically preserve patient or provider choice between telehealth or in person care. And we still want to make sure that patients have access to in person visits when they're appropriate. And then finally, CMS released a draft regulation to preserve certain telehealth protections until the end of 2023 for Medicare beneficiaries with specifically with mental health conditions. And that would continue to remove those geographic restrictions and allow patients to use telehealth from home, among other things. It would also require an in person visit within 6 months prior to the first telehealth visit and at least once every 6 months after. Regarding clinical guidelines, they could also play a big role. So currently, many providers may not know when it's appropriate to use telehealth versus in person, but clinical guidelines for each specialty could help provide clarity, ensure that telehealth is being used appropriately, and ensure that patients are still receiving in person visits when they're deemed medically necessary.
Great. Well, thank you both. I think we have a few questions from the audience, so let's take a look at those. So here's a question, Ted, I think for you. Family caregivers often play a significant role in their loved ones' medical appointments. How can they remain involved in telehealth appointments?
Well, I think they can remain involved as much as they currently are. The difference would be that they're involved, from home. Um, I think it takes a significant burden off the caregiver, depending on how advanced the Parkinson's is. But all the difficulty in traveling to and from, as I mentioned, it's a movement disorder. Falls are a major issue for Parkinson's patients. So anything that can be done to eliminate some of those hazards, I think, is a positive. And for the caregiver, it takes some pressure off of them to have to make all the arrangements and be responsible for the physical well-being of the patient. So I do see significant benefits for the caregiver.
Great. So a second question we have here, Ted, I think is for you as well. So Parkinson's is an area where clinical trials play an important role. Does telehealth help further clinical trials?
I believe that there is more ability now to use telehealth for clinical trials. I'm not the research expert here at the foundation, but we do see promise in utilization of telehealth. And one other comment I just want to make is, and it had been mentioned before, I believe, by the American Telemedicine Association, but what we're talking about here isn't a different type of care, or it is care. It's practice of medicine, and I feel that the time we're in now is the transition period to full acceptance of telehealth as one more alternative for how to get one's care. We're pushing for permanence of telehealth. We do believe that it's an equity, as much as anything else, something to create greater equity within our healthcare system.
Okay, great. Well, one last question, and Stacey, I'll throw this one to you. So, how has telehealth impacted care and coordinating interpreting services for ESL or deaf and hard of hearing? Any thoughts on that issue?
Yeah, you know what? I haven't heard much about that, but I would think that with ESL, as long as you have, that video component and you can sign and read lips, it would still be helpful. Unfortunately, I don't have a lot of information on that to give you a good answer. I apologize.
No, no, no worries. Ted, I wonder if you have any thoughts on that. I guess I'm thinking of the deaf and hard of hearing portion of the population as well.
I haven't run into it specifically either, and we haven't heard from clinicians about it. But with Parkinson's, one of the longer term effects is eventually, oftentimes, losing basically the ability to speak. Another symptom is the frozen face, where people can't smile and things like that. And so I could see there being obvious issues with telemedicine in certain circumstances where the ability to communicate has been impaired. So I think, I think those are the types of issues that a physician would say, hey, now, I really need you in here, so that they can assess what's going on.
Sure, makes sense. All right, well, that's all the time we have, but thank you both, Ted and Stacey. I appreciate your being here with us today.
Thanks so much.
So next we'll hear from another patient whose life and medical treatment has been impacted by telemedicine. Jamie Sanders is a prolific blogger, a mother, and an ardent advocate for people living with migraine disease. We recently asked Jamie to share her experiences using telehealth services to manage migraine. Let's take a look now.
During the pandemic, telehealth became increasingly necessary in order to stay on top of not only migraine, but my mental health as well. I could utilize video or telephone appointments, as well as email to discuss medication adjustments, add new treatments, or any changes in my symptoms. If I did not have access to telehealth during the pandemic, my disease would have become more severe and difficult to manage. Without the ability to safely go onto an emergency department or urgent care center, it was imperative that I was able to reach my headache specialist and his team so that I can receive the proper medications to treat myself at home and stay on top of migraine. Telehealth provides easier access to healthcare, especially for migraine patients who may be unable to physically get to an appointment if they are in the middle of an attack. It allows patients to be more compliant with keeping their scheduled appointments, and it allows for more flexibility. As a migraine patient who relies on treatments like Botox and nerve blocks, I still need to go into the office to receive them. Unfortunately, during the pandemic, I was unable to receive these treatments, which caused a setback in the number of attacks I was experiencing. Telehealth cannot be substituted for therapies that require an office visit, and many migraine patients need to have that available on a regular basis. Without telehealth, migraine patients will not be able to see their healthcare providers as often as necessary. Many of us have to drive long distances to get to our doctor's offices. I have to drive 2 hours one way just to see my headache specialist. Telehealth allows me to stay in contact with my doctor more often and eases the burden of travel whenever I have new symptoms that do not require an office visit. All in all, telehealth is a must in keeping in contact with our physicians, especially for those of us with migraine, when our symptoms change frequently, our medications are no longer effective, and we have questions but cannot take that long drive or take time off from work or are just too sick to get to the office. So it's important that we keep telehealth an option and available for all patients.
Thank you, Jamie, for sharing your perspectives on telehealth as a person living with migraine disease. For our next discussion, Lifeline, how telehealth policy can reduce disparities, we're going to highlight two interesting programs, one in Arkansas and one in Colorado, that are using telehealth to reach underserved populations. We're going to explore how telehealth can be used to reduce disparities instead of exacerbate them. So I'm joined by Rosalind Perkins, an advanced practice registered nurse at the University of Arkansas for Medical Sciences, and Stephanie Coe, manager of speech and learning services at Children's Hospital Colorado. So Rosalind and Stephanie, thank you so much for joining us today.
Thank you for having me.
Stephanie, Stephanie, I want to start with you. So we actually just heard an audience question in the last segment about how are we using telehealth and how is that working with our deaf and hard of hearing population? So this is actually great that you're the first person speaking after that question comes. So I just want you to first start off by telling us about the telehealth program that Children's Hospital Colorado is running, which provides care for the deaf and hard of hearing community in Colorado.
Yeah, thank you for the opportunity to share our program and our successes with increasing accessibility for our patients and families who are deaf or hard of hearing. Our speech and language department has been offering telepractice or telehealth since 2012 amidst various populations of need, mostly families who come see us as we're a regional pediatric hospital. They come see us all over from rural areas of Colorado and surrounding states. So as we were well primed to shift to telehealth full time when our clinics closed in March of 2020 at the onset of the pandemic. And that allowed us to really treat more families with deaf and hard of hearing and recognize the inequity of telehealth and patients who are deaf or hard of hearing or their parents who might be hard of hearing as well. Through telehealth, the signal is at times degraded, and you may hear someone talking and you might be able to read lips, but if you don't rely on lip reading, and that's not a skill you have, and you have a mild hearing loss, then we have found that closed captioning would help close that gap. We were fortunate enough to get a grant to help do a pilot project with closed captioning with this specific patient population.
Okay, Stephanie, so tell us a little bit more then about that grant you received, because that might help answer that question from the audience member that we heard earlier, which is, how are you using telehealth if, just as you said, lip reading isn't something that somebody is good at, or perhaps, you said that signal is degraded and so what you're hearing isn't matching up with what the mouth is doing. So talk to us more about that specific grant that you received that's really helping to elevate the level of care you're providing to these families?
Be happy to. The our patients who are deaf and hard of hearing or their family members who have hearing loss um, struggle to understand what's being said through computer speakers as the signal's degraded. So unfortunately at that time, our video conferencing software didn't allow for closed captioning. So with the grant, we were able to run a pilot project to use closed captioning with our patients and families during speech and language therapy. We oftentimes turn it on or might turn it off depending on the goals of the speech language pathologist, but always have it on during parent education and patient education for home practice to ensure that they're understanding what their plan of care and what activities we ask them to do over the following week as part of therapy progress. So this grant helped pay for that additional expense for closed captioning software to be used for therapy, which then allowed us to be inclusive for all of our patients to access telehealth successfully.
So it sounds to me like telehealth can work well for the deaf and hard of hearing population, but we need to take some other considerations, and that includes perhaps closed captioning to really be able to elevate that level of care. So thank you for sharing that, Stephanie. Rosalind, I want to turn to you. So the University of Arkansas for Medical Sciences, you've been running this high-risk pregnancy program for almost 20 years now, and it has a major telehealth component. So tell us a little bit more about this program.
Okay, thank you again for having me here. Back in 2000, we started this program in 2003. Arkansas is a big rural state. Out of 75 counties, 74 are designated as medically underserved. So we, just based on history, we found that a lot of babies were being born with heart defects. Nobody knew it, until they showed up there and they delivered. A lot of preemie babies were being born out of facilities at facilities that did not have NICU, neonatal intensive care units. So wanted to focus on that and create access to high-risk OB care around the state of Arkansas, no matter where you lived. And this it came together with a contract through our Medicaid, our Arkansas Department of Health, our Arkansas Medical Society, and the University of Arkansas for Medical Sciences. So that's how we got started. The way the program works, we utilize a 24-hour, 7-day-a-week call center. Is pretty much our entry point for referrals, for transports, for patient triage. And we do a lot of telemedicine clinics. So our moms around the state are seen locally. We have sites across the state of Arkansas. We have 64 locations that can be connected. The majority of the days we use about 25 of those sites to see patients, moms that are advanced maternal age that couldn't get to Little Rock because we started out, all MFMs were just here locally in Pulaski County, which is dead center of Arkansas. And so people are coming in across the state. Some people would have to drive 2 hours, some 3 hours, so we came up with this program and we've been doing a really great job. Education is a big major component also.
Okay. So, Rosalind, as you mentioned, Arkansas, it's a rural state, and really interesting to hear that 74 out of 75 counties are considered medically underserved. We also know that infant and maternal health outcomes for Black and other minority communities are worse. So, tell us a little bit about how your program helps to address some of those disparities.
Okay. This program helps to address some of those disparities by, like I say, creating that access. We want to make sure all moms get care no matter where they live. So we have telemedicine, again, like triage. We have case managers that reach out to those patients. Also, we have gone to using a lot of phone service, cell phones and things like that, because even in some of the areas we don't have good broadband. Patients don't have access to internet or good internet. I remember where a patient had to leave her home and go to just say like a local library or something to be seen. So now we use a lot of telephone services, and we are getting grants to get broadband pushed out further into our rural communities. In the Delta, I want to go to the Delta since we're talking about Black moms and the disparities. We have an area in Arkansas that runs from on the east side, southeast up to northeast. And we are able to see patients in those areas utilizing some of our AHECs. They can come in and be seen, or be seen if it's just a face-to-face consult. They can use their cell phone and be seen. So hopefully we're decreasing those disparities in these areas. Also, I just want to add that when we started out in 2002, it was around 26% of preterm babies were born where they should be. A lot of times they were delivering in small hospitals and being transported, which we both, everybody knows that's not good for baby. And since this program started, we're up to greater than 55% of those preterms are delivered in the appropriate facilities with neonatal intensive care units.
That's fantastic progress. So you mentioned there, Rosalind, broadband, and we heard from Congresswoman Marionette Miller Meeks earlier today from Iowa all about rural broadband. So I want to ask a poll question to our audience about this, and that is, in 2019, the Federal Communications Commission estimated how many Americans lack broadband internet access. Excuse me. So A, 21 million, B, 23 million, C, 16 million, or D, 31 million. And so I am able to see the results here live, real time. And we'll give it just a few seconds to get some answers in here. All right, so about 50% think it's B, 23 million. The answer is A, 21 million, but I've also read some articles that thinks that number is way higher than 21 million. But the point is, it's a lot, and perhaps a lot of those people live in Arkansas as well, which is why there's a need for the expansion of the broadband internet access there as well. So this is going to be actually my final question for both of you. And so Rosalind, I'll start it with you. How can we ensure these innovative telehealth programs, just like the one that you're administering, and you've kind of touched on this earlier, but maybe just talk about it a little bit further. How do we make sure they don't exacerbate these existing health disparities and inequities that exist?
I feel like what we can do to not exacerbate these problems is to see the appropriate patient in the appropriate venue, meaning if there's an abnormal fetus, that mom needs to be seen in-house or in our traditional healthcare setting. Also, I alluded to using cell phones. Like I said, a lot of poor people don't have good internet access, but everybody has a cell phone. And that with COVID, I heard somebody mention earlier, we were able to see more moms do telephone visits, even if it's just a phone call, also use their cell phone to do a face-to-face telemedicine visit. So those are some of the things that we practice to not increase or exacerbate the problem that's already there.
Great. And Stephanie, your thoughts on this?
It's a good question because in today's world, our patients are coming in, children and parents, with masks, and masks also inhibit a child or a parent's ability to hear, especially if they have hearing loss. So we found great success with telehealth, and definitely want to make sure we do everything we can to connect with families via telehealth when possible, to be able to offer closed captioning and successful speech language therapy for this population. as Rosalind had said, cell phones are very useful as well. I find technology continues to advance. And here in Colorado, we found a lot of our rural families have internet, and our video conferencing software continues to improve in order to function successfully on lower signals, which helps us connect with our families as well. So with that, closed captioning allows us through the telehealth format to access patients and families that live in rural and underserved areas and don't have access to a speech language pathologist who specializes in working with kids with spoken language and deaf and hard of hearing, as well as modeling to the kids we see that closed captioning is necessary and a part of what they need. And if I want to share a quick story, we had an 8-year-old boy that was part of the project accessing closed captioning during his therapy. And one day he signed in and the closed captioning wasn't there. He immediately said to his therapist, I don't see the words, which was amazing that one, he advocated for himself, and two, he recognized the fact that he needed closed captioning in order for that therapy session to be successful.
Yeah, Stephanie, I know I said that was my last question, but I want to follow up and just have you maybe give our audience a sense of some of the challenges that people in Colorado may face too when it comes to accessing care, which is why they need access to telehealth. I'm thinking about people who live in very small mountain towns and there's a snowstorm and they can't get out of their house for a month at a time. So just maybe educate the audience a little bit. We heard Rosalind talk about the Delta. Talk to us a little bit about what Coloradans face.
Sure. We have rural areas both east and west of the I-25 corridor. So Denver sits in the middle of Colorado, and we have families on the western slope who have very limited access to town, especially during the winter months. I worked with a little guy up in the mountains that weather was always a factor. And then I've also worked with a family on the eastern plains where they lived on a dirt road, and most of the wintertime home health struggled to get to their house because of the conditions of the roads. So we're pretty much off east-west of I-25 corridor, gets very rural, as well as limited number of speech language pathologists available to serve such wide rural regions. And so having telehealth program allows families to access care consistently, regardless of the weather, regardless of sibling illnesses, regardless of transportation issues that may impact their scheduled schedules.
Great. Well, Rosalind and Stephanie, we love the programs that you're running. We would encourage people to learn more about those, see if you might be able to implement something similar in your state. And thank you so much for joining us today and sharing your insights.
Thank you.
Thank you.
For our final perspective of the day, we are going to hear from Dr. Michael Ruma, a maternal fetal medicine specialist from New Mexico. So Dr. Ruma, go ahead.
Susan, thanks so much for having me. I really appreciate the opportunity to visit with you. I brought a few slides if I could show you those today. Great chance to share a physician's perspective, a maternal fetal medicine specialist. We actually were just listening to that wonderful telehealth program in Arkansas. I'll tell you a little bit about myself, so next slide. As a first and foremost job, I'm a maternal fetal medicine specialist. I work for Perinatal Associates New Mexico in Albuquerque. We have a wide variety of offices, and I'll tell you a little bit about that in a moment. I also do some work from a variety of other companies outside of my primary job. Some of those are Hologic, Obix, as well as Philips Ultrasound. Next slide. Perinatal Associates of New Mexico is a private practice. We have been in the state for many, many years. Currently have 4 MFM physicians. We have over 100 team members that help serve patients throughout the state. 25 sonographers, which you'll see on the next slide, is useful for us to scatter out throughout all of the different offices we have. If you can show us the next slide, please. We have 4 major physician offices, just as you heard previously. Denver's kind of in the middle of Colorado, Arkansas and Little Rock is the major city. In New Mexico, obviously, Albuquerque is the largest metropolitan area, and we've scattered physician offices throughout the state, as well as satellite ultrasound offices, where we're primarily seeing pregnant women doing their ultrasounds, and that was the way we were using those in the last several years. And obviously, that changed, though, in the COVID pandemic. Next slide. We do over 30,000 annual fetal ultrasounds. We look very carefully at the heart. We look at very unique pregnancies like this monoamniotic triplet pregnancy. That's a 1 in 10,000 pregnancy, very, very unique. Next slide, please. As you can see in this image, this is kind of what our job looks like on a daily basis. You have a physician with a happy couple looking at an ultrasound system, embracing their new pregnancy. We're taking all kinds of images, surveying anatomy, evaluating how the fetus actually looks in utero, and everything is hopefully normal. That's the way our paradigm has been structured up until this new era of telemedicine and telehealth, which has really dramatically changed in the last 2 years during the pandemic. Next slide. As a maternal fetal medicine specialist, we're responsible for taking care of mothers' medical needs, hypertension, HIV, infectious difficulties, pregnancy complications like preterm labor, complications with fetal anomalies, and we're really trained to detect, look at the mom as a whole individual, the pregnancy as a subsequent medical individual we're taking care of as well. And we do a lot of care coordination for that image that you see above of an open neural tube defect. We definitely don't want that particular baby born in a rural community because that baby needs neurosurgical services. And so we do a lot of care coordination with people like these folks in the helicopter here. Next slide. I know all of us, we've become very familiar with telemedicine over the telephone and using different apps that integrate into electronic medical records, and we've used that highly successfully. This is just an image of what that can look like within our practice. Next slide. We use in our practice that particular telephonic and video interface to do genetic counseling, diabetes management, pre-pregnancy visits. We've done it a lot to avoid having COVID patients that are infected come into our office. So if we have a screen positive test, we're evaluating those patients as well. But the thing is, we do a lot of ultrasound. Obviously, we need to touch the patient. I'm maybe in Albuquerque or Santa Fe, but we have patients down in Roswell, 4 hours to the south, maybe way up in Farmington, 4 hours to the north. So how do we actually care for them without having to have them travel to us? Next slide, please. So we conducted a FDA pre-approval trial looking at a really brand new perinatal telemedicine solution. And fortunately, we did that right prior to the pandemic in January and February of 2020. We looked at 30 patients. We evaluated how well they liked and accepted telemedicine, where I actually am able to be contacted anywhere really in the world from one of our ultrasound systems to do a visit. Next slide. As you can see here on the left-hand side, you see an ultrasound system, you see a webcam. The sonographer in the remote area is able to actually reach out to me. I am able to do this via an app on a PC, and then you can see me on the right-hand side taking control of the ultrasound system, taking images, communicating with my sonographer, and actually communicating with the patient to complete not only the ultrasound visit, but also to be able to complete that important telemedicine consultation, talking to the patient, managing her blood pressure medications, talking to her about any fetal anomaly that we may have discovered, and developing a plan remotely. Next slide, please. This is just an image of what this looks like on a day-to-day basis. This is me talking to my sonographer, Stacy. You can see the control panels on the left-hand side where I'm actually able to take control of the system. Next slide. We've been utilizing telemedicine over the last 6 years, since about 2016. And you can see the numbers in blue, 356, 334, 486. Those are total visits. We're trying out telemedicine. With the pandemic in 2020, dramatic increase to 5,100 visits. And as of September, 6,500. Next slide. Telemedicine distinctly in all types of our visits, genetic counseling, diabetes management, maternal fetal medicine visits, nurse practitioner visits. If you look at the trend lines, we definitely are seeing ongoing desire and need for telemedicine throughout our entire medical practice. Next slide. We are looking at ways to use telemedicine. How do we grow new visits? We don't necessarily need more brick and mortar visits. We can do all of these visits with smaller genetic counseling, diabetes management, MFM consultation. We can do that now in a much smaller footprint. Next slide. We're distinctly saving travel for patients, for our clinical staff, and we really can share our whole host of expertise, not just with physical offices, but to patients within their own homes as well. We don't need to do in-person visits for consultations, for pre-pregnancy visits, for perinatal behavioral health, for genetic counseling. Last slide. Telemedicine distinctly has allowed us at Perinatal Associates New Mexico to serve patients better. It reduces those access issues, driving 4, 6, 8 hours to see a subspecialist. It definitely improves patient compliance. Patients come on, talk to our diabetes specialists with a lot greater certitude and a lot greater show rate. They don't no-show anymore because they can do this from their home. It distinctly decreases disparities in our state. New Mexico has 23 tribal nations. Those tribes are spread out all throughout the state in very rural areas, and the telemedicine has allowed us to reach those patients. It helps us be flexible for the patient and the patient to be flexible with us. And I think there's a huge whole host of undiscovered future benefits. We just need to keep this access of telemedicine going within the United States. Thanks so much for taking the time to listen to me today.
Sharing those images with us. Absolutely fascinating technology and what we were able to do there to care for our high-risk pregnant moms. Now it's time for our final segment of today's summit, Quick Fix, the pros and cons of on-demand virtual care. We've all probably had an experience where we need to see a clinician and quickly. Are healthcare apps the answer? We'll explore that question today as we hear the views of the patient and provider communities about the rise of direct-to-consumer apps you sometimes see advertised on television, as well as those that may be offered by your health plan. We'll talk through the pros and cons of these apps and consider how policy can balance access with comprehensive patient care. I'm joined for this discussion by Dr. Claude Pirtle, Chief Medical Information Officer at West Tennessee Healthcare, an internal medicine specialist. Welcome, Dr. Pirtle.
Hey, Susan, thank you for having me.
So my first question for you, Dr. Pirtle, is just tell us a little bit more about these virtual healthcare apps, this idea of on-demand care from an app.
Absolutely. No, this is definitely something that's come up in the last few years. As you can imagine, it's a blooming field over the past few years, not only because technology, but also broadband has become more and more prevalent. If you think back, we've been doing telehealth at some capacity for decades, if you consider the telephone, telehealth, which it is, audio-only version. So over the years, we have become more and more, I guess, sophisticated, if you will, to get these applications. Hence, the on-demand care, really those apps that we talk about on your iPhone or your Android device, become more and more prevalent because it's easier to use. Everyone has a cell phone. It's ubiquitous, as you can imagine, in the United States and really around the world. At the touch of your phone, you can talk to a physician. And just to take a quick step back, I know we talked a lot about telehealth, but the thing, telehealth is really an umbrella around asynchronous, synchronous health, synchronous visits, which is telemedicine visits, is what you think of. Synchronous being a telemedicine visit with your phone, like face-to-face with your physician. Asynchronous being you take a picture and you forward it to somebody. And also mHealth and remote patient monitoring. mHealth being those Apple kits, Apple Watches, things like that, Fitbits that you could use. And you've seen a lot of third parties and also payers have, they want to kind of know what's the patient doing. Is he following his diet? Is he working out every few days? Things like that. So the rise of remote patient monitoring and really telemedicine has become more and more prevalent. If you can imagine, pre-pandemic, I think it's been mentioned probably 2 or 3 times, but CMS actually had less than 13,000 visits pre-March of 2020. But right a few months after, they actually said they had over 1.7 million visits a week they were doing in telemedicine. And that's what's so important about policy is having that piece in there, in allowing that opportunity for not just Medicare patients, but all Blue Cross, Blue Shield, Cigna, all the private payers also to allow patients to to really enact in that care. So that's the on-demand app version has come up more and more because now it's in your hand. you can see a doctor within a few minutes. Interesting enough, they had a survey come out about a week ago that showed that telehealth adoption, of course, spiked across all generations, young and old, most notably for convenience and the ability to receive care very quickly. However, it did mention specifically in the direct-to-consumer and also the payer-sponsored telehealth apps that people were kind of concerned about patient satisfaction due to limited services and also some inconsistent care and ultimately cost confusion, which I think probably the biggest win in regulatory piece is the cost confusion piece. Pre-telehealth, pre-pandemic, we really not a lot of physicians use telehealth mainly because of cost confusion. There's originating side, distance side, Medicare didn't pay for asynchronous visits. There was a lot of different rules. Hence, with the emergency declaration certificate, really has relaxed a lot of those and improved really quality of care for a lot of people.
So, Dr. Pirtle, from your perspective as a clinician, are these apps good? I mean, I can name a half dozen that I see advertised on TV, or I get served ads when I'm on Instagram or Facebook. I mean, it's definitely true that they offer a lot of access for patients, especially for those who might struggle to get care because of provider shortages, for example. So, are they good? What are your thoughts?
Well, quite a question, Susan. The short answer is they do fill a gap. So the gap is there, specifically, as you mentioned, in health professional shortages areas, as the people right before mentioned, same situation. But the narrative really is around that patient and the patient care, really that care ecosystem. You're going to hear that a few more times. I do think the apps can be beneficial, such as relatively healthy. Maybe they're sick at 9 o'clock on Friday afternoon. They're unable to get to their primary care doc. It's not quite ER related. How I teach telehealth is really low acuity issues, right? If somebody has crushing chest pain, shortness of breath, et cetera, those are not real telehealth issues. But low acuity, healthy patient, and he wants to seek a higher level of care, yeah, absolutely. On-demand telehealth could come in there. But the thing is, it's access and convenience, right? That's what we're really looking at here. The thing I worry about is the fragmentation in care. How does your primary care doc know? Now, yeah, if you're 20 years old and really have no medical problems, the chances are very, very low that things are going to change. But you may have maybe 50, 60, 70 years old with multiple comorbidities and you're taking medications, right? Your primary care doc may never know you've seen a telehealth visit, that you may have been treated twice for a UTI already with antibiotics. So you're having your primary care physician in the conversation at all times is probably the most important piece. But I think the real answer here is that they do serve a purpose and they do have a gap that needs to be closed, such as I think earlier segment about Colorado and some very rural areas. Same thing in Tennessee. But once again, going to that fragmentation, that care ecosystem, you may take medications that you don't even know may exacerbate symptoms you already have or comorbidities you have, or treatments that you may be receiving very soon. So, for example, you may have a follow-up visit with a cardiologist that may change you to your blood pressure medicines. Well, if the cardiologist calls you in a medication that you've been on for years, however, you introduce a new medication from an on-demand provider, it may cause issues. So the point of it is always check with your primary care specialist to make sure that any new medications or new treatments are in line with what you're taking now. During the pandemic, as mentioned, those visits skyrocketed. But for years before pandemic, they were saying, different survey, by the way, but surveys were showing that patients want to see physicians or even other nurse practitioners and PAs that they're very familiar with. So they already know the provider. That's very, very important because that bond, that trust bond is already there. So I'm CMIO and also Assistant Chief Medical Officer, but I still practice in internal medicine. I know my patients, at least they tell me, they want to see me or my nurse practitioner that people they're very used to seeing and knowing that, hey, Dr. Pirtle's seen me, he knows my care, he knows my last 5 years, 10 years of history, and I know I'm doing the right thing. In some states, actually, have started pushing towards that provider-patient relationship before allowing pay parity in some instances with some of the on-demand docs, on-demand telehealth. I know there's a few, not to say anything specific, few out there that do erectile dysfunction, they do hair loss, they do all these things. My point is, though, is yes, for the most part, they're safe, and there's a place for some of those, but always do this in conjunction with your primary care physician.
Great. Okay, so I want to ask our audience a poll question, which I found totally fascinating when I researched this. So according to the IQVIA Institute for Human Data Science, how many new consumer digital health apps were released in the year 2020? Okay, that's only over the course of 12 months. Is it A, 10,000, B, 45,000, C, 90,000, or D, 120,000? So we're going to give it just a few seconds for people to put in their answers. And we'll see if our audience has been doing research on this as well. Just a few more seconds. Okay, actually our audience, well, they're split 50-50 between B and C. The answer is C, 90,000, which I just found to be absolutely an incredible number, and it makes me curious how many are going to be introduced in 2021. So, Dr. Pirtle, how do we balance then getting patients immediate access to care while also protecting their health and maybe even their privacy? Because it's pretty obvious that these apps are here to stay and there's only going to be more of them.
Very, very good question. And actually, I did not know that 90,000 application. That's a that's a large number, especially in such a short time period. Just to take this a two-part question, if you will, the relationship of on-demand telehealth and your primary care physician is something that's going to coexist, not only for the convenience factor, but also the access piece, right? Going back to the health professional shortage area. Those are very important to have. People need access to care. They need to follow up. They need chronic disease management. They need psychiatric access if needed. However, on-demand is not the panacea, if you will. So the push for the hybrid approach is where it's going to stand in a synchronous relationship with your primary care doc. Now, going to your question about privacy, that's very, very, very important. I think we all have seen the massive privacy statements on our iPhone or Android. I'm sure everyone reads it diligently every day just to understand what's going on. But the truth is there's a lot of verbiage in there and how your information is going to be used. So privacy risks really involve the control or their lack of control of how your data is collected and also shared with others. So, for example, home health devices and sensors that may be given to you by your primary care doc even, or on-demand services, third-party on-demand services and payers, they collect a lot of information such as falls, some apps on your phone, and very familiar, Facebook and Instagram and all these other, Twitter, they collect a lot of data, a lot of information. And you may not know how that data is going to be used, such as, for example, you wear a wearable device, it tracks you everywhere you go. So just be careful and very cognizant about how that data is going to be used and who's going to have access to that data. Some people may not like their phone sharing that data. So point of it is always be aware of that. Interoperability, so whenever you see an on-demand service, that data may never get back to your primary care physician. So once again, who's going to share that record? There's some strides in ONC at the federal level to try to improve that. There's something called a continuity of care document. It's a standard form that is what data is shared between physician to physician or hospital to physician. But a lot of those laws and regulations really haven't made to the third-party piece. Now, I know the FDA is stepping in to try to bridge that gap, but it's still not wholesome quite yet. It's important to, if you do see an on-demand telehealth provider or a payer, please be sure to follow up with your primary care doc, update them with new medications, procedures, etc. Any failures of medications are also very, very, very important. So, for example, you've been on antibiotics given to you by a telehealth company that's out of the state. Your doctor wants to know that. Also, I would ask if this is your purview, right? I would ask, hey, are you licensed in my state? Going back to that originating in distant site, pre and post pandemic, that I think is going to come back, or at least in some instance, once the declaration is cooled down just a little bit and COVID has decreased. Also, ask the physician or even an intake, how are you going to use my information? Where does it go? Does it go to the cloud? Does anybody know where it goes? Or have some follow-up about that? And lastly, tip that I would ask is, are you going to follow up my primary care doctor? Are you going to send that CCD? Are you going to send an ADT message, which is an admit, discharge, transfer, or any type of messaging to that primary care physician, just so that he or she knows that you're being treated? And if not, hey, can you send me something that I can give to them, just so you create that full narrative? And your physician or NP, PA knows exactly what's going on in your care. But privacy, obviously, absolutely one of the most important pieces now. I know there's a lot of strides with Apple and other groups to protect that privacy, but you're in control of your information and you want to know where it goes. So.
Well, Dr. Pirtle, this is fascinating. You obviously are a wealth of information when it comes to these things. So thank you for sharing your perspectives with us today. It's definitely been informative.
Absolutely. Thank you very much.
So last week I had the chance to talk with Tanya Winders, President and CEO of the Allergy and Asthma Network, to get the patient perspective about these on-demand virtual care apps. This is my conversation with Tanya. Tanya, thank you so much for joining us today.
Thank you for having me.
So Tanya, what does optimal care for respiratory patients look like?
Well, optimal care and respiratory care really comes down to the entire patient pathway. When we're talking about prevention, diagnosis, treatment, and long-term management of chronic diseases like asthma and COPD. And so, of course, that's changed over the course of the last 18 months to 2 years to certainly incorporate more telehealth and remote monitoring tools.
Okay. So it sounds kind of like there's a multidisciplinary approach to this, where there's many different specialists and things trying to manage the patient. So, can you talk a little bit more about how the pandemic has actually altered the way that the patients, you talk to and serve, are engaging and accessing care?
Absolutely. So what we know is that it does incorporate both primary care and specialty care. When we talk about a multidisciplinary team approach in chronic respiratory conditions like asthma and COPD, it could include a respiratory therapist, a primary care provider, a allergist, pulmonologist, very broad multidisciplinary care team. And over the last 18 to 24 months with the pandemic and all of the shifts, certainly we've seen patients are much more open to leveraging technology, to conducting telehealth visits, either by phone or by video, by incorporating some of the remote monitoring tools that are available, like spirometry at home or pulse oximetry, to manage their conditions more effectively. So that incorporation of telehealth and remote monitoring, and really looking at how they can manage their chronic disease more effectively with that multidisciplinary care team has taken center stage.
Okay. So, with the rise of these on demand virtual healthcare apps, which we've been talking about today, many patients can now see a provider get a very quick fix and be on their way. And on its face, this seems like a great option for patients, but I'm curious to hear your perspective. Do patients agree with that viewpoint? Are there any pitfalls to these apps?
I think it can be a double-edged sword, right? So with all good things, there's also some downsides or pitfalls potentially. I think for patients, it's opening up access. So what we've heard is that, again, no longer do patients have to take an entire half day off to go to the doctor or have their routine care visits. That can be done from the comfort of their home or their office or even their vacation spot. And so there's that greater access to those physicians through telehealth. However, unfortunately, telehealth doesn't lend itself well to procedures. And so if you're talking about spirometry or fractional exhale nitric oxide, there's fairly limited access to those tools in the home setting or the remote setting. And definitely when you talk about, just kind of that multidisciplinary team approach with pulmonary rehab and the more complicated patients, oftentimes telehealth hasn't stayed up or caught up with, the ways that patients want to access these resources and treatment modalities.
So can you talk a little bit about the importance of the medical home and how you feel like these apps can aid in that, or if perhaps they don't aid in that, but kind of talk about that concept and that idea of the medical home and how important that is for respiratory patients?
Well, it's vitally important for respiratory patients to feel that they have a medical home. That is a single provider that's coordinating their care, that's certainly helping them to know what they need and how to access what they need, right? And so we think that it's, again, on the part of the patient to take responsibility for their long-term management of these chronic respiratory conditions and to utilize the tools at their disposal. Now, whether that's health applications, mobile applications, we have one in severe asthma that tracks daily symptoms, medication use, that they can then share with their provider what their moods were, how their activity levels were impacted, all of these, different data points over time. But the key issue for us is that the patient take ownership of that data, of that medical record, and be able to share it appropriately. Because as you know, we don't have interoperability, we don't have universal shared data or medical records across the system. And so it's really incumbent still on the patient to take that ownership and the willingness to share it with their providers appropriately.
Yeah. So it sounds like these types of apps can be really good for patients because they open up access, but it also comes with a level of responsibility, you might say, on the patient as well to be able to share that information with their core care team. So my last question for you, Tanya, is really about the policy because we're at a policy summit here today. What do you think can be done to increase access for patients? I mean, we know that these apps are here to stay and there's a lot of them. They're coming on the market every single day. How do we ensure access but also maintain that comprehensive continuity of care for patients?
Well, it's a great question. And I think it's one that has both regulatory and potentially legislative solutions. So, first of all, we need better regulatory pathways for these solutions. Right now, unfortunately, FDA really doesn't have very clear, transparent pathways for remote monitoring devices, for companion diagnostics. So there's many opportunities for us to accelerate the regulatory pathway for these solutions and get them into more hands. Secondly, legislation. We know that we have made great strides when it comes to telehealth parity over the last 2 years in the midst of the pandemic. It would be a travesty if we see those legislative efforts roll back to the day that they were before, where there wasn't parity, where what was done over a telehealth visit was not reimbursed like it would be in clinic. So we are advocating for that at Allergy and Asthma Network, certainly trying to ensure that the strides that have been made during the pandemic continue to roll forward and that the adoption and behaviors of both providers and patients continue to leverage these really, innovative tools that can change the face of how treatment is delivered.
Great. Excellent points, Tanya. Well, we appreciate you joining us here at the Getting Telehealth Policy Right and National Summit. We appreciate you bringing the perspective of the patients that you serve, and we thank you for joining us.
Thank you for having me.
So thank you so much to Dr. Pirtle and to Tanya for that interesting insights about on-demand virtual care apps. So I am now going to turn it back over to my colleague Amanda to wrap up today's summit.
Well, thank you, Susan, and thank you to all those who joined us today, either as participants or attendees. We're also grateful to the sponsors of today's summit, Amgen, Horizon, Johnson & Johnson, and Neurocrine Biosciences. We've seen incredible advances over the last year and a half, and it's exciting to live in a time when patient-centered care can take so many forms, whether that's an in-person visit or a telemedicine consultation from your smartphone, whether it's touching base with your regular provider or getting the insight of a specialist hundreds of miles away. We're grateful for the experiences shared here today, and we're hopeful that continued advocacy will protect policy gains for patients in the months and years ahead. Thank you for joining us. Enjoy your afternoon and be well.